So Roshni, on a countdown of 10, can you start? Already it's live, right?
Yes, sir. Yes, sir.
Yeah.
We can start, sir.
Hi, good evening, everyone. Thanks for attending this webinar. I would like to welcome Dr. Vivek from MPI to set the context for this meeting and take the event forward. Over to you, Dr. Vivek.
Thank you, Shrikant. First of all, on behalf of Molecular Pathology Association of India, I welcome all the esteemed faculty members, resource faculty members, and the delegates for attending this educational event virtually. And I would proudly take this moment and proudly state that Molecular Pathology Association of India has been successfully organizing these seminars very frequently. And we have organized three hands-on training to pathologists and on HER2 low and ultra low scoring interpretation and series of educational webinar. And this is the eighth webinar of this year 2025. So today we are going to have this webinar on emerging biomarkers in lung cancers. As we all know, the diagnostic and treatment landscape of lung cancer is rapidly evolving with the integration of emerging biomarkers, which notably are MET genomic alterations like overexpression or amplification, or HER2 overexpression or mutations, and then TROP2 expression alongside improvement in the molecular diagnostic targeted immunotherapies. These advances are more enabling us to be having more precise patient selection, better outcome, and to select the new line of therapies, in particularly antibody drug conjugates, have emerged as a powerful, fast advancing treatment option for non-small cell carcinoma of lung. And coupling these tumor antibodies like HER2 or TROP2. So these developments span for optimized detection, MET overexpression or amplification, and refined HER2 mutation or expression profiling, and pragmatic ISC-based selection for top two are enabling more precise patient selection and better outcome. A new line of therapy across the biomarkers in non-small cell carcinoma of lung. So through this webinar, let's understand and learn more about the emerging and the upcoming biomarkers such as MET, HER2, TROP2, and what are the recent advances in the treatment for associated with these biomarkers. So for this meeting, we'll start and let's invite Dr. Santosh Reddy, who is from Omega Hospital, Telangana, to take this session on evolving landscape in lung cancer. So uh, yes, can over to you, Dr. Santosh.
Uh, Good evening, sir. Hope I'm audible, sir.
Yes, yes, you are audible.
Yeah, I'm sharing my screen. So you can see my screen, everybody, right?
Yeah.
My screen is visible, right? It's full screen.
No, it's not in full screen.
Now it's full screen.
Yeah, perfect.
Yeah. Good evening, everyone. I'm Dr. Santosh Reddy. I'm a consultant medical oncologist from Omega Hospitals, Karimnagar. First of all, I want to thank IAIU and MPI along with AstraZeneca for giving me this wonderful opportunity in discussing about evolving treatment landscape in lung cancer. So, without wasting any time, I'm proceeding further. As you know, lung cancer, the majority of the lung cancers, it can be non-small cell or small cell. In non-small cell, we have adeno and squamous in majority of the portion. Whereas the molecular marker subtypes, if we see in adenocarcinoma, based upon these molecular markers, the landscape of the treatment in lung cancer has changed drastically. Previously, 1 to 2 decades ago, it was only chemotherapy was the standard of care in the lung adenocarcinoma in metastatic setting, where the overall survival was around like 8 to 9 months. But after the molecular oncology has stepped in, so if patient is having EGFR or ALK or something, the patient from the 9 months of the survival, it has jumped to almost now from 5 years to 8 years around with the help of the molecular marker precision uh, targeted therapy. So if you see lung adenocarcinoma, there are different kind of molecular subtypes. Right now we have, so the majority of the times we have EGFR, KRAS, ALK, and other markers which are seen in only 1 to 4%. But if you see about the EGFR, it is seen in 30%, whereas in whereas it is also 30%, ALK 4 to 6%. In the real world scenario also, we have our own data from Omega Hospital, around 400 patients we have taken. So we have retrospectively evaluated how many patients were having EGFR. So around 39% were EGFR positive, around 8 to 9% were ALK, and KRAS was seen only in 15% of patients in the real world from our institute. So if you see like EGFR exon 19 del or L858R, there is a wonderful drug called osimertinib. So if at all patient is being mutated with the EGFR or L858R upfront, we'll be starting on osimertinib. So, but even after starting osimertinib, the patient can have a median PFS of around 18 to 19 months. After that, the patient will be having an acquired resistance on osimertinib. The resistance can be of different types. It can be on target or it can be off target. On target, it can be EGFR kinase domain mutations, which is seen in 13% of patients. It can be like C797X, L792X, L1780, and so on. If you see off target mechanisms, it is bypass mechanism. The most common we can see is MET, or we can see HER2. MET amplification is in 15% of patients, whereas HER2 amplification is in 2% of patients. And if you see the histological transformation, not only about the on target or off target, histological transformation, if you see, it can be seen in around 5 to 15% of patients, small cell, or it can be a squamous cell. All these things are the acquired resistance to osimertinib. It means the patient who has been started on osimertinib upfront for exon 19 del or L858R, these patients subsequently they can have a resistance mechanism on usage of osimertinib. So the same thing it has been given here. So definitely, if the patient has been developed resistance after the first line tyrosine kinase inhibitor treatment, so definitely there is an unmet need for effective treatment for patients with advanced EGFR mutation, NSCLC who develop resistance to first line TKIs. So if you see in advanced EGFR mutated NSCLC, the resistance profile after first line progression is complex. So in the real world or in the guideline, patient upfront chemotherapy naive or targeted therapy naive, patient is being diagnosed with lung adenocarcinoma, metastatic setting. Patient is having EGFR exon 19 del or L858R, and the patient is started on third generation EGFR, like osimertinib. If at all patient is taking osimertinib, subsequently after 18 to 19 months, most probably the patient, if at all, if it develops resistance to osimertinib. So in the next line, we should have a repeat biopsy if possible, or if the biopsy is not feasible for any reasons, the patient at least should have a liquid biopsy. So in all our patients, we are doing a liquid biopsy or a repeat biopsy, the patients who progresses on osimertinib. So in the pocket study, the most common mechanism of resistance, if at all a patient has been progressed on osimertinib, the EGFR alterations and MET amplifications are the most common mechanism for the resistance. The same thing has been studied in ORCID study. If at all the patient is having EGFR exon 19 del or L858R, the resistant mutations, if you see EGFR alterations are seen in 40%, whereas MET amplifications 24%, whereas other mutations like BRAF is seen in 6%, AKT, P10, and PIK3CA, which was seen in 11%, and HER2 alterations, it's 2%. The optimal treatment for patients who have progressed on first-line EGFR directed TKI monotherapy will likely involve targeting specific resistance molecular pathway. After doing the repeat biopsy or the liquid biopsy, we'll come to know the patient which kind of alteration the patient is having so that we can target exactly on that alteration for the benefit of the patient. So, as we discussed earlier, the MET is a major driver of first-line resistance to osimertinib. So, if you see the MET uh, based upon the aberrant activation of MET receptor tyrosine kinase pathway, there will be overactivation of intracellular signaling, which results in the cell growth, survival, and proliferation. Already, it has been studied. It has been known fact from the from papillary RCC, gastric, colorectal, and lung cancer. It is a common kind of alteration. So MET alteration in tumors can lead to resistance to first-line TKI. So the patient who has been started on EGFR tyrosine kinase receptor, third generation TKI specifically. So in those patients, the MET alterations is commonly seen as a resistance alteration, as a resistance pathway. So there will be the EGFR tyrosine kinase signaling will be decreased, and in the same way, there will be crosstalk exists between the signaling pathways from the EGFR as well as the MET. So there will be an increase in MET-driven signaling bypasses, inhibition of EGFR-driven signaling. Thereby, the tumor cell will proliferate continuously despite the EGFR blockade. It means the patient who progresses on osimertinib after having the resistance pathway, the patients even after giving the osimertinib, if you continue, there won't be much benefit without addressing the resistance pathway like MET. So there is a different kind, like a patient who has taken osimertinib upfront, or the patient who has taken the first generation or second generation tyrosine kinase. It means like in a EGFR mutated lung cancer, there are different kind of first generation, second generation, third generation tyrosine kinase inhibitor EGFR, right? So in the first generation tyrosine kinase inhibitors like EGFR, like uh, eftanib or erlotinib, thereby if at all the patient, not every patient will be affordable for osimertinib. So the patient who was started on first generation or second generation tyrosine kinase inhibitor, those patients they develop EGFR 3790M is the most common resistance mechanism after giving the first and second generation TKI. These kind of patients they will respond to osimertinib exceptionally well. Other way around, if the patient has been given first line osimertinib in EGFR exon 19 del or L858R, these patients have the resistance common resistance mechanism has met. These patients, even after continuing osimertinib, there won't be of much benefit. So if you see the trial going on, Savannah trial and ORCAD trial, these are the phase 2 trials. The patients in the Savannah trial were the patients are received osimertinib 80 mg plus savolitinib 300 mg who already progressed on first line osimertinib and had met as a resistance pathway. Thereby, it has been based upon IHC and or FISH. So these patients have a median duration of response after giving the osimertinib along with the savolitinib. The median duration of response was 9.9 months. The median time to onset of response in weeks was 6 weeks. The median PFS was 7.5. The same way, the ORCID trial, it is also a phase 2 trial. It is a biomarker-driven study of osimertinib plus savolitinib in patients with EGFR mutated non-small cell lung cancer who progressed on first-line osimertinib monotherapy. These patients should have having MET amplifications or MET exon 14 skipping mutations. So these patients were given osimertinib 80 mg once daily along with savolitinib 300 mg or 600 mg OD until the disease progression. These patients were also uh, these patients were having the stable disease There was one patient who having stable disease less than 6 weeks, and there is a complete response. There is partial response in 7 patients. So these are ongoing trials who have been addressing the osimertinib plus savolitinib in the patients who were having MET alterations or amplifications. It's a phase 3 data, saffron phase 3 study. Patients who are having MET plus exon EGFR mutated NSCLC. It's a phase 3 randomized open label trial of savolitinib in combination with osimertinib versus normal chemotherapy, platinum-based doublet chemotherapy in patients with locally advanced or metastatic EGFR mutated positive NSCLC who have progressed following the treatment with osimertinib with MET as a mechanism of resistance. All these patients were received upfront osimertinib and the disease have been progressed. So these patients were having MET as a mechanism of resistance. These patients were included as an eligibility criteria. So these patients were given osimertinib along with savolitinib. It has been compared with the normal, basically standard chemotherapy, pemetrexed plus cisplatin or carboplatin. The primary endpoint was progression-free survival, whereas secondary endpoint was OS in MET IHC positive and objective response rate. So it's an ongoing trial. So now coming to the after the MET, coming to the HER2 protein expression. So as we know in the Western data, the HER2 protein expression in the lung adenocarcinoma is around 3 to 4%. But in the real world, which we have seen in our institute, it is around 11%, that too mostly in the females. So this HER2 should not be compared with the HER2 as in breast. It is different when compared with the HER2 expression in the lung in comparison to the breast. So HER2 protein expression or amplification or gene mutation may lead to oncogenic activation of the HER2 pathway. So PRBB2 has three major type of alterations. It is not only it is HER2 overexpression, or it can be HER2 amplification, or it can be HER2 mutation. HER2 overexpression, it means an overabundance of HER2 expressed on cell surface of the tumor. Whereas HER2 amplification, it is abnormally high number of HER2 gene copies. Whereas HER2 mutations, it is multiple mutated loci. Alterations can result in hyperactivation of the HER2 pathway, which may drive oncogenesis through gene transcription, tumor cell survival, proliferation, invasion, and metastasis. So if you see the difference between HER2 mutation and overexpression or gene amplification, HER2 mutation, we see majority of the times it is non-squamous histology, majorly in adenocarcinoma, for light or never smokers and in women especially. Overall incidence is 2.8%. All HER2 mutation represents 3.6% of NSCLC population. HER2 mutation, if the patient is having HER2 mutation, it is a negative prognostic factor. It's a poor responder to the chemotherapy. HER2 mutation is mutually exclusive to EGFR and ALK, anticipated to the PDL1 low or negative. In our subset, in our database, all the HER2 mutation patients are PDL1 negative. So HER2 mutation may confer resistance to the first line anti-PDL1 therapy. Coming to the HER2 expression or gene amplification, these are also majority non-squamous histology. It is seen in 24% of NSCLC who's having IHC 2 plus, with only 3 to 10% being IHC 3 plus. Incidence of amplification is uncommon. Around 3% of NSCLC are HER2 amplified. This is correlated with IHC 3 plus, but not IHC 2 plus, which is seen in 24% of patients. Overexpression is also associated with poor prognosis. Amplification is not. So, as we know, already HER2 is doing HER2 targeted therapies are doing exceptionally well in breast cancer, in stomach cancer, in GE junction cancers. All all the cancers where the HER2 has been expressed, they are doing very good. Even the gallbladder cancer also, the HER2 expression is also a negative prognostic factor. But in the lung, if at all patient is having HER2 positive NSCLC, there are ongoing trials, PDXD trials, Destiny Lung 02. It is Trastuzumab deruxtecan in previously treated HER2 mutated metastatic NSCLC. All these are in the second line setting. Uh, so in Destiny Lung 03, it is an ongoing trial. It is also PDXD and durvalumab in combination with chemotherapy for treatment of patients with advanced or metastatic non-squamous NSCLC and HER2 positive. The next ongoing trial is Destiny Lung 04 PDXD as first line treatment for unresectable, locally advanced or metastatic NSCLC harboring HER2 exon 19 or 20 mutation. Hopefully, we can get a positive results as like in breast or in stomach. So we have to wait for the results. So if you see the ongoing trial, a dose-blinded, randomized, it's a multicentric, international, non-comparative phase 2 trial. So if you see the eligibility criteria, it's a metastatic HER2 mutated NSCLC patients were enrolled, more than one prior anti-cancer therapy, including the platinum-based chemotherapy. These patients were enrolled. So with a good performance status, so these patients were given a study design of PDXD 5.4 mg per kg or 6.4 mg per kg. So these results were awaited yet still. So it's an the data is not mature yet. So if you see DCR, it is 95 in PDXD 5.4 mg per kg, whereas in PDX 6.4 mg per kg it is 46. So duration of response, it is almost similar with the 5.4 versus 6.4 mg per kg. So next highlight of the upcoming marker in the lung. So already we know top2 is doing good in breast cancer as well as in urothelial cancers. It's already approved. So in breast we have sacituzumab govitecan, whereas the in urothelial cancer also it has been approved. So now it's turn of lung. So it's new molecule and a new entity. So we have to know how it should be tested and how it has to be assessed and how many patients like in the real world we have how many patients will express TROP2 and how the responses will be there after taking the TROP2 targeted therapies. It's still awaited. So we are eagerly waiting. So we'll discuss about high TROP2 expression has been identified in lung adenocarcinomas as well as in squamous cell carcinoma. So it is tested as IHC in lung adenocarcinoma and squamous cell carcinoma. It is same like HER2, if I'm not wrong, but now esteemed panelists will be discussing about how it has to be tested. So the protein levels based on the intensity of membrane scoring scored as weak to strong and to proportion of TROP2 based upon the percentage of total staining was scored as and TROP2 protein levels were considered low if at all score is of 0 to 4.5 or high score of 5 to 6. So proportion of patients with TROP2 protein expression on IHC, if you see lung adenocarcinoma, it is 100%, whereas in squamous, it is 92%. Whereas proportion of patients with high TROP2 protein levels, if you see 64% of the lung adenocarcinoma patients are having high TROP2 protein levels, whereas 36% of patients having TROP2 low in lung adenocarcinoma. In the squamous cell histology, 75% of the patients express like TROP2 high in squamous, whereas 25% is only TROP2 low. So as you know, dato-DXd monotherapy and osimertinib plus dato-DXd efficacy. These are also like ongoing trials and data is not mature and not in the guideline. So we are eagerly waiting for the final results. So the response efficacy dato-DXd 6 mg per kg and the data 6 mg per kg per year osimertinib. So the confirmed object response rate, if you see DATO-DXd in all patients, it is 42.7, whereas in DATO-DXd per year osimertinib, it is 44.8. If you see the median PFS and DATO-DXd, 6 mg per kg is around 5.8. Whereas in ORCID study also, PFS by DATO-DXd cohorts, osimertinib plus DATO-DXd, it is 4 mg per kg, it is 9.5, whereas osimertinib plus DATO-DXd 6 mg per kg, it is 11.7. So Propion Lung 15, it's an ongoing investigation to advance DATO-DXd in the treatment pathway. Now the TROP2 is a new entity. So they have been trying drugs so that there will be a benefit for the patients. So the ongoing trials are there. Still the results are awaited. Hopefully the result will be positive so that we can use in our patients. So it is also phase 3 open label sponsored blind randomized study of DATO-DXd with or without osimertinib in EGFR mutated NSCLC after progression on osimertinib. So it's also ongoing trial. Results are awaited. So my key takeaways. So at least in a lung adenocarcinoma patients metastatic setting, definitely EGFR, ALK, RAS, BRAF, and KRAS is being must. So if all patient is affordable, I'm doing NGS in all my patients, irrespective because it's a government has been funding. So I'm doing NGS in all my patients. So if at all a patient is having EGFR exon 19 del or L858R, it's always good to start third generation EGFR TKI if patient is affordable. So definitely osimertinib will be a first choice. And as per the FLORA data, or we can give osimertinib plus the chemotherapy as per the FLORA 2 data. So after the patient having disease progression on the third generation EGFR TKI, definitely there is always an indication for a repeat biopsy. If at all repeat biopsy is not feasible, definitely you push the patient for the liquid NGS or liquid NGS so that we can get which kind of resistance pathway the patient is been having so that we can we can target exact the resistance pathway. It can be a histological transformation, it can be a HER2, or it can be a MET. So MET is a major driver of first-line resistance to osimertinib, as we discussed. HER2 protein expression or amplification or gene mutation may lead to oncogenic activation of the HER2 pathway. So new kid in the block, high TROP2 expression has been identified in lung adenocarcinoma and squamous cell carcinoma. So eagerly waiting for the results. So yeah, so this is my talk. Thank you for giving me this opportunity.
Thank you, Dr. Santosh. It was a very informative talk, and I would say you have educated us about the recent treatment advances in lung cancer. So before we move on to our next agenda, the audience can put their questions in the Q&A box, and we will take it on later on all the questions. And we move on to our next agenda. I'd like to invite our next speaker, Dr. Trupti Pai, who is professor in pathology in TMH Mumbai. So to take us through the detail about the emerging biomarkers in lung cancer. Over to you, Dr. Trupti.
Yeah. Thank you, Dr. Vivek. I will just share my screen. I hope it is visible. Is the screen visible?
Yeah, it's visible.
Okay, okay. So very good evening to all. So after looking at the treatment landscape in lung cancers, so next 15 minutes, we will look at which are the emerging biomarkers in lung cancers. So I will be taking these three biomarkers, that is MET, HER2 and TROP2. We will see what are the different alterations. Like we always hear that there is overexpression, amplification, mutation. So what is the difference between these alterations? So what are the different testing methodologies and what are the updates and guidelines pertaining to these markers? So first coming to MET, that is mesenchymal epithelial transition. So it is a cell membrane tyrosine kinase receptor for hepatocyte growth factor. And we all know that MET pathway plays an important role in cell proliferation, migration, invasion, and this is implicated in oncogenesis. So which are the different MET alterations? So we know there is MET overexpression. That is, there is increased protein expression of MET, or there can be MET amplification. That is, there is increased number of MET gene copy number, or there can be a MET mutation. That is, there is change in the DNA sequence. So what happens with all these alterations is that there is increased MET receptor expression. So whenever there is increased MET receptor expression, there is increased downstream signaling pathway. So we always hear that this MET is a very important biomarker when it comes to post-osimertinib case scenario. So what it does that whenever there is increased MET protein expression and increased downstream signaling pathway, the tumor cells proliferate continuously. So despite there is EGFR blockage, there is this bypass mechanism that is ongoing, and this leads to resistance of EGFR TKI. So how do we test all these alterations? So MET protein overexpressions, we will test with IHC immunohistochemistry. MET amplification, that is, we are looking at the gene copy numbers. So primary testing methodology is FISH, that is fluorescent in situ hybridization, in which we make use of fluorescent label probe, which directly bind to the gene, and we can see how many gene copies are there in comparison to the centromeric probe. Also, it can be detected with NGS. And what about MET mutations? So primary testing modality is NGS. And whenever we are looking at fusions, mostly it is the RNA-based NGS testing, which is preferred over a DNA-based. So coming to the MET exon 14 skipping alteration. So it is seen in approximately 3% patients with NSCLC. So if you see the clinical scenario, it is mostly seen in older age group with a smoking history, advanced disease. And histologically, if you see this, the tumor morphology is not very differentiated. It is a very sarcomatoid kind of a tumor, where sometimes even to call it carcinoma is very difficult on histology. Sometimes you get all sarcoma markers and it is really very difficult. So whenever you see this kind of morphology, there is always at the back of the mind that this can be a MET exon 14 skipping alterations. And we know that it is a very poor prognostic factor. So what exactly happens in MET exon 14 is that there is this mutations either in the exonic region or in the intronic regions. And what happens is that there is a complete deletion of exon 14. So exon 13 and exon 15 come close to each other. Now this exon 14 is very critical in causing the degradation of the MET receptor. So whenever there is this loss of exon 14, there is decreased degradation, and that is how there is increased MET expression. So how do we test this? It is again tested with NGS, and as I mentioned before, RNA-based NGS is preferred. And what happens if there is exon 14 skip mutations? It is a predictive biomarker for the MET TKI. So some points on the MET amplification. So de novo MET amplification is seen in approximately 1 to 6% of NSCLC cases, and post osimertinib, it is seen in approximately 20% cases. So here there are increased gene copies, and that is how there is increased MET expression and increased downstream signaling pathway. So FISH is a primary methodology. So always if you see, there is very controversy regarding MET amplification, like what is the exact scoring? Some say that ratio more than 2 of MET versus CEP7. Some say some trials take into account MET average gene copy 5. Some take the ratio more than 5. Some take into account average gene copies more than 10, 15. So it is always a very controversy regarding what exactly is the cutoff for the MET amplification. Also, this can be detected with NGS. Again, high-level MET amplification is a predictive biomarker. Now we have always come across amplification and mutation, but now there is increased this data about the MET expression. So MET expression de novo is seen in approximately 25% of cases, whereas it is seen in approximately 29% of cases with post-osimertinib. So this MET protein overexpression can be because of amplification or mutation, or maybe some post-transcription modification. So whatever is the alteration, ultimately it leads to increased protein expression, and it is linked to a poorer outcome. So we'll test this with IHC. And now with the updated guidelines, MET IHC is recommended at some point during progression, depending upon the tissue availability. So if you see until Jan 2025, when it comes to IHC, it was just the HER2 IHC, which was like recommended by the guidelines. But after the Teliso-V approval in the May 2025 update, even CMET IHC is recommended at some point during progression. So we all know we usually go up with the upfront tissue-based NGS, and on progression, we ask for liquid biopsy. So this is like an important point to make, that now there is this approval or some recommendations regarding IHC to be done again on progression. So MET IHC and HER2 IHC. So these are two IHCs which are now recommended by the guidelines. Okay. Now, when it comes to IHC, we should also know what is the criteria or the cutoff of positivity, which clones are recommended. So in this guidelines, they recommend. So whenever you come for a IHC for a biomarker, you usually see what is the intensity of the staining, whether it is mild, moderate, strong, or we call it 1+, 2+, 3+. That is one criteria. And another thing is how many percentage of tumor cells are showing this percentage positivity. So with CMET, it is the more than 50% tumor cells having 3+ membranous staining pattern. So whenever this is the staining pattern, there is this approval for Teliso-V. Okay, so this cutoff is important. So approximately what proportion of patient progressing on osimertinib are expected to have MET-driven resistance? So again, if you have different cutoffs, you will have different percentages. So whenever the cutoff was low, that is IHC more than 50%, 3+, or on FISH more than 5 copies, the approximately 62% of all patients showed MET expression or amplification. But if you increase the cutoff, so most of the trials now, like the Savannah trial, it took into account IHC strong 3+ staining in more than 90% cases, or on FISH if you have more than 10 copy numbers. So when you have this, so approximately 34% of patients showed MET expression and or amplification. So we already came across this trial data in the previous talk. So in the previous trials, so we have seen it was mostly the MET amplification, which was done by tissue NGS, and it was in the range of 24% and 17%. In the Savannah trial, again, to reiterate, IHC and or FISH, there was approximately 34% of patients having, so there is increased percentage of patients showing MET expression and or amplification. So again, whenever there is any IHC based test, we should know what clone. So these are all like a companion diagnostic. So in this trial, the IHC that was taken was of the Ventana assay clone SP44, and the platform was Ventana benchmark platform. The criteria initially to start with was IHC 3+ in more than 50%, but finally it was refined as IHC 3+ in more than 90% cases. When only IHC positivity was considered, the prevalence was approximately 29%. Coming to the FISH, it was the Vices MET FISH probe by Abbott, and the criteria used was more than 10 average gene copies. And when it was just the FISH alone, the prevalence was 20% of MET amplification. So all the platforms will have its own pros and cons. When it comes to IHC, we know that it is very widely available. We all have mostly IHC platforms with us, and it is a quick turnaround time. Okay, but with challenges, it is like there are different clones that are available in the market. So there is difference in reproducibility, accuracy. There is difference in sensitivity, specificity. So these points have to be taken into consideration whenever you are using IHC. Nevertheless, it is one of the best platforms when you want to deal with the expression studies. What about FISH? FISH is very sensitive. It is the gold standard when we are dealing with the copy number alterations. You can test it on a very tiny tissue. Even a single section of 2 to 3 micron is enough if you want to do FISH. But you need a fluorescent microscopy. It needs a technical expertise. It is a very costly, and like in terms of turnaround time, it is more than IHC. Coming to the NGS, in NGS, it is a massive parallel sequencing. You get the details of most of the genes, different alterations in one go. But again, it is a labor intensive, expensive. needs technical expertise, and TAT is definitely an issue. It is longer than both IHC and FISH. So you have all the platforms IHC, but tissue is always an issue. So in lung, it is not just the quantity, but also the quality that matters. And whenever you are dealing with this biomarkers, which are like on progression, you just can't use the baseline biopsy. You need to have the biopsy, which is post progression. So selection of the tissue, how much is the tumor percentage, all these things will matter before you interpret. And what happens, even if you see in the guidelines, it is like you have to do all these markers. So basically upfront NGS is the standard of care. But if you have tissue available on progression, you can do this IHCs. In breast, like you have a pragmatic approach that you do IHC. 3+ is fine. If you have 2+, you will go ahead with FISH. Similarly, this can be applied in MET for the MET alterations in lung tumors. So tissue IHC followed by FISH is the most effective in identifying MET overexpression and amplification in EGFR mutant patients post first line third generation TKI. So this can be applied again depending upon the quantity of the tissue that is available post progression. Coming to HER2. So we know HER2 is one of the 4 receptors in the HER family. So you have HER1, HER2, HER3, HER4, of which HER2 is most commonly we encounter, and it has the most potent kinase activity of the HER family. Similar to MET, it also has like gene mutations, amplifications, and or overexpression. So testing methodology, if you want to test HER2 mutations, so most significantly, what we say is a YVMA duplication, exon 20 alterations, exon 19 alterations, like mutations. So for whenever you want to deal with mutations, primarily the testing methodology will be NGS. Also, it can be done by PCR, but primarily it is done as a broad spectrum using NGS. And you can do this on tissue as well as on the liquid biopsy. Same with HER2 amplification. It can be done with FISH and NGS, and again, it can be done on tissue and liquid. But HER2 overexpression, when you want to study, it will be done by IHC and only on the tissue. It is not done on the liquid. So what percentage of this HER2 alteration? So if you see, it is a very significant biomarker in breast, gastric, biliary tract, gastroesophageal junction tumors. And in NSCLC, if you see HER2 3+, it is seen in approximately 1 to 5% patients, and amplification is seen in approximately 1%. We commonly encounter doing HER2 mutations in lung cancer, which is seen in approximately 2 to 4%. So is there any concordance between like the concordance that we see in breast? Similar, is it encountered in lung? So what is the concordance of HER2 amplification and HER2 IHC? So if you see, there are a lot of patients in which lot of tumors, lung tumors, in which there is HER2 overexpression, which is not accompanied by HER2 amplification. So that is, if you want to identify HER2 expression, you have to do IHC for HER2 protein expression. Similarly, is there a concordance between the HER2 mutations and HER2 protein expression? So no, there is no overlap that is identified between the HER2 3+ and mutations. So there are these different destiny trials. You have pan tumor, you have colorectal, lung. So what is the scoring criteria that is used? So most of the tumors apart from breast, if you see, they take into account the gastric HER2 scoring. So in gastric HER2 scoring, it is different for the biopsy specimen and for the resection specimen. In breast, you consider the circumferential membranous staining. In gastric, even lateral, basolateral, incomplete membrane staining is enough. Even the criteria is different. So for all this pan tumor, colorectal and lung, we will consider gastric HER2 scoring. And why is it that so? Because it takes into account heterogeneity. Okay, so we have to keep in mind that any other tumor apart from breast, we will consider the scoring system of gastric. So what are the guideline recommendations for NSCLC? When will you do protein? Will you do protein expression HER2? So yes, in advanced and metastatic NSCLC, we will do HER2 protein expression by IHC and HER2 mutation testing by NGS. And which tumor? So it is non-small cell carcinomas, adenocarcinomas, and it also can be considered for a squamous cell carcinomas. So the recent NCCN, we have seen that even HER2 IHC and MET IHC have been implicated in the progression setting. So again, which clone? So it doesn't mandate any specific clone for HER2. Scoring, as I already mentioned, gastric HER2 scoring will be applied. And about the positivity, it will be the 3+, which will be eligible as a predictive marker. So IHC 3+. So coming to the last biomarker, TROP2. So TROP2, that is a trophoblast cell surface antigen. Now this is the upcoming new marker. It is a glycoprotein receptor on the epithelial membrane surface. It plays a role in the intracellular signaling pathway and is involved in cellular growth, renewal, proliferation, and transformation. So there are many epithelial tumors, solid tumors, which have been shown to have high levels of TROP2. So there is limited expression on the normal epithelial tissue and there is increased expression on the tumors. So we have data now for TROP2 overexpression in NSCLC, especially more in squamous carcinomas as compared to adenocarcinomas. Similar is seen with the triple negative breast cancer. Now coming to the prognostic implications. So it has been shown that high TROP2 has increased cellular proliferation, angiogenesis, and metastasis. So indirectly, it connotes like a poor prognosis, and it is definitely a predictive biomarker. So what happens with the high TROP2 expression is that there is extracellular matrix remodeling, which indirectly supports the tumor progression and metastasis and also supports the angiogenesis. So from a predictive point of view, we know that there are these TROP2 inhibitors which have, it is very difficult to pronounce, so I will just restrict to TROP2 inhibitors. And also when it comes to immune checkpoint inhibitors, it has been shown to have an inferior response. So tumors with high TROP2 have shown to have an inferior response to immune checkpoint inhibitors. Okay, so definitely it is a promising target in lung cancer. So overall, overexpression is seen in lung, mostly in squamous carcinoma, also seen in adenocarcinoma. It connotes a poor prognosis with enhanced metastatic and invasiveness, and it is definitely a promising therapeutic target. What is unique about TROP2 is that the scoring mechanism. It is not like usual. So again, you have different IHC clones, you have different criteria. Different tumors have taken different criteria. Like some have taken more than 50% tumor cells with 1+ intensity. Some have taken more than 10% cells with 2+ intensity. So that cutoff is not fixed. But what is unique is that with the digital algorithm and the normalized membrane ratio, there is a quantitative scoring system. And I'm sure it is going to be covered in the next talk. So that is very unique about TROP2, and we all are very excited for the results of the trial. So to summarize, MET overexpression and amplification is seen in approximately 34% of EGFR mutant patients via IHC and FISH. So this expression will definitely be missed by NGS and liquid biopsy, which we usually do in routine practice. So we have to keep in mind that there are some markers for which IHC has to be done. That is overexpression of HER2 and MET. Gastric scoring system will be applied for HER2 scoring in lung cancers. Guidelines does recommend this MET IHC and HER2 IHC on progression. And TROP2 is broadly expressed in NSCLC, more in squamous and in adeno, and is recognized as a promising molecular target for therapeutic development. So I'm very thank you all for patient hearing, and thanks to the organizer for giving this opportunity. Thank you.
Thank you, Dr. Zipti, for giving an valuable insight and details about the MET overexpression, amplification, HER2 overexpression, and of course the testing methodologies and the scoring systems and the interpretations that we use for the HER2 expression, and update on the latest guidelines also, and also like enlightening us about the top to the testings and all these things. So now we'll move on to the next session, and I hope this session has been very informative to the audience. Coming on to the next session, I would like to invite Dr. Shubhankar Basak. This is diagnostic lead in AstraZeneca. He's from Bangalore, and he'll take us through the QCS next generation computational pathology. So let's hear more from more about what QCS is from Dr. Basak. Over to you, Dr. Basak.
Thank you, Dr. Vivek. Thanks for this opportunity to MPI as well. Good evening to all the participants and my fellow facilitator, presenters. Dr. Vivek, can you just confirm whether my screen is visible or not?
It's visible. Just go to the full screen, I guess.
Is it okay?
Yeah, that's fine.
Okay, great. Thank you so much for confirming. So next, maybe 15 minutes or so, I'll try to highlight about a new concept Trupti Madam talked about, QCS, the quantitative uh, continuous scoring, which is the next generation computational pathology. So for immunohistochemistry, there is a set criteria, right? Looking into the staining pattern, looking into the intensity of the staining. So what is the need of QCS? So in next few minutes, let's try to understand the genesis of this, why it's required. Then I'll gradually take you through the how to run the QCS and how to do the scoring and all. Please note one point. This is an evolving field, very new. We also have limited information, but I'll try to give you a holistic view so that you can understand the concept here. Okay, so in the beginning of 20th century, one of the famous scientists, Paul Ehrlich, given a concept of magic bullet. Many years after, in May 2001, first targeted therapy, that's the Gleevec, got the US FDA approval. And Times Magazine put it into their front page. They mentioned this is the new ammunition in the war against cancer, magic bullets, and these are revolutionary pill. So the time has come in 2001 to targetedly deliver the medicine into the cancer cell so that it can kill the cancer cell without affecting the healthy normal cells. After that, drug discovery scientist has done many different type of research, to increase the specificity of the delivery vehicle, increase the lethality of the potency of the drug. A lot of small molecules, lot of monoclonal antibodies came, and the new poster boy is antibody drug conjugates. And the scientific world's calling them as biological missiles. Why? Let's look into the structure of the antibody drug conjugate. So as the name says, it's an antibody and it has a drug conjugated into this. So the antibody is the guided system for the cytological drug, right? It goes and binds to the target antigen so that delivery of the cytotoxic drug happens into the point where it needs to be delivered. It also having a linker. The linker is actually the bridge between the antibody and the drugs, and it also controls the release of the drug at the right time, at the right place, and this also provides the stability to the whole molecule. And the cytotoxic drugs are the warhead which actually destroy the cancer cells. Dr. Santosh also mentioned about a couple of ADCs. And these ADCs are leading to a new era of targeted cancer therapy. Let's look into the mechanism of the ADCs. Very interesting. So the ADCs first, I have given the example of TROP2, but it's almost the same for all different ADCs. So ADCs goes and bind to its antigen. Then the internalization process happens through the mechanism called endocytosis. Once it goes inside the cell through the method of endocytosis, then the lysosomal degradation happens. It breaks the antibody and gradually release the payload. And once the payload gets released, it gradually enters nucleus and then it starts its act. It's either disrupt the microtubule, which leads in inhibition of cell division, or it inhibits the topoisomerase 1, which actually uncoil the chromosome during the process of replication, and that leads to cell death. It's also having a very interesting mechanism. It not only work on the cells which expresses the antigen, but it also released from the cells and go to a neighboring cell which is having a low level of antigen expression or absolutely no expression of the antigen, diffuses into that and also impact the cells and leads to cell death. And that's called the bystander effect. Now, there are multiples of ADCs. You can see here in the right cartoon about 18 ADCs so far got approved. There are multiple ADCs, 1088 ADCs are the preclinically active. 366 are clinically active, but simultaneously, you can see about 800 ADCs are preclinically not active or those are discontinued. So a large number of ADCs also failed. And this has been linked to the unresolved efficacy and toxicity due to low drug internalization rate, how the drug getting internalized, or low levels of target antigen expression and off-target toxicity due to inadvertent drug release. So let's look, Dr. Trupti mentioned about the TROP2. Let me reiterate very quickly about the TROP2 and the anti-TROP2 ADCs. So TROP2 or the trophoblast cell surface antigen 2, it's actually a glycoprotein of 323 amino acids, 35 to 49 kilodalton, its molecular weight. And it's actually encoded by a gene called TACSTD2, which is the tumor-associated calcium signal transducer 2. And this gene is located in short arm of chromosome 1. It has three different domains: the extracellular domain, transmembrane domain, and the intracellular domain. It's actually highly expressed in many solid tumors. But the interesting is, its expression is pretty less in the normal cells. It actually binds to the insulin-like growth factor 1, and then it interact with many different pathways within the cell and help in embryonic and fetal growth in the normal cell. But in case of malignant cells, it actually helps in tumor progression and migration. And the nature of its expression, it's highly expressed in solid tumor, as I have mentioned earlier, and less in normal cells. That makes it an interesting target for the drug discovery scientists. In the squamous NSCLC, about 60% of the cells it expresses. In adenocarcinoma, it's a bit less, around 42 to 64%. And another very interesting factor, and we'll discuss this later, it also expresses within the cytoplasm of the malignant cells, which have been, the data have been published in 2010 by a Japanese group. But the role of this cytoplasmic expression is not clear, though. We earlier speakers discussed about two anti-TROP2 ADCs in lung cancer, especially sacituzumab govitecan and datopotamab deruxtecan. For SG, there is a warhead or the cytotoxic drug called SN38. And in case of datopotamab, it's the deruxtecan. Very promising drug, but let's look into the different challenges with the expression of TROP2. So does good targets always guarantee success? It's actually not. There are two different studies has been done, one in sacituzumab govitecan, another with datopotamab deruxtecan. TROP2 expression analyzed retrospectively with the traditional system, looking into the different score of 0, 1 plus, 2 plus, 3 plus, and no staining, and less than 10% cell, so on and so forth. But surprisingly, the result shows responses occurs regardless of TROP2 expression in both the clinical trials. So it actually shows the conventional IHC scoring has not predicted the response of TROP2 directed ADCs in certain tumor tribes. So what to do now? Can TROP2 expression used as a predictive or therapeutic response to Dato-DXd? Two very interesting study outcome presented very recently, one in 2024 WCLC and another in 2025 this year in European Lung Cancer Congress. The first study which shows the normalized membrane ratio. I'll talk to about QCS and the normalized membrane ratio in next couple of slides. But let's look into this, what this paper says. This says the normalized membrane ratio of TROP2 quantitative continuous scoring is predictive of clinical outcomes in tropion lung 1. And similarly, the tropion pan-tumor 2, which is a study on the Chinese population, this also shows a trend towards increased ORR and longer PFS in Chinese patients with TROP2 QCS NMR tumors who received Dato-DXd. So both the trial shows if you do not look the expression of TROP2 through the conventional system, rather through a computational pathology AI algorithm model in a different way, the trial's able to predict the therapeutic response of Dato-DXd. Based on that, there are two trials are going on. One is Avengers study and another is Tropion Lung 10 study. Both are phase 3 randomized and open levels trials, which actually looking into the association of TROP2 QCS NMR with efficacy of Dato-DXd. Then the discovery scientists also try to look at what are the rationale behind that. A very important study outcome came in American Association of Cancer Research annual meeting in 2025, where the group from AstraZeneca actually done a lot of experiment in cell lines H322, its knockout and overexpressed cell lines, along with multiple other NSCSC cell line and isogenic xenograft mice model, CV17 SCID mice. And they have given a very crisp 3 points. TROP2 membrane expression is required, but not sufficient to predict the anti-tumor efficacy of Dato-DXd in clinical tumor models. Despite similar levels of Dato-DXd binding across a panel of NSCLC cell line, differential internalization capacity of Dato-DXd is observed. So membrane expression is not the only thing, and the internalization of the molecule plays a significant role here. And this study also mentioned TROP2 QCS NMR predicts Dato-DXd internalization capacity and Dato-DXd efficacy in NSCLC cell lines. So now let's look into what is TROP2 NMR and what is QCS. So QCS is a novel supervised AI-based computational pathology approach. And what does that mean by supervised AI-based computational pathology? It means the AI algorithm that are trained on digital images containing annotation made by the expert pathologist. And by using QCS to determine TROP2 expression, the NMR can be calculated. Now let's try to understand what is exactly. So in the conventional IHC, the pathologist looks into the pattern and the intensity of some percentage of cell in the tumor tissue. But in case of QCS, the name itself says is the quantitative continuous scoring. So first step is the digitization of the slide. Once the digitization happens, then the algorithm looked into all the different cells in the tumor. So it can differentiate the tumor from the non-tumor. The AI algorithm can understand the staining of the membrane and cytoplasm. It actually measures the optical density of each tumor cells of its DAB staining. And then it actually normalized the membrane ratio with membrane OD with the membrane and cytoplasmic OD, that's the total optical density, and give it a binary number. And the samples were considered TROP2 QCS NMR positive if more than 75% of the tumors had NMR less than 0.56. The samples are considered TROP2 QCS NMR positive if more than 75% cell of the tumor cells showed NMR less than 0.56. That means it's not looking to some portion of the cells. It looks into the entire slide, each of the cells to the digital model. Then apply AI on top of that. Look into the optical density of each cell's cell membrane as well as the cytoplasm, and then calculate or rather normalize the membrane ratio and gives a binary number which should be less than 0.56 in more than 75% of the cell, so that it can be considered as QCS NMR positive. So that means the higher the cytoplasmic staining, higher the or lower the membrane ratio, higher the response of dato-DXd. So that means, as I mentioned earlier, the internalization of ADCs are very, very critical, and that's what it's showing. Dato-DXd must be internalized to release the cytotoxic payload, lower NMR predictive of the response. Going forward, multiple other trials will be read out from next year in different conferences, and we'll come to know more about why 0.56, why it's more than 75% cells. So those are some of the answer we also need to understand. Most probably we'll be understanding going forward in 2026. Now, several other data also showed in different non-squamous cells NSCLC, the TROP2 QCS NMR positivity is above 66%, more than 2/3, and squamous cell a bit less. Now, please remember this algorithm of QCS has been developed by the digital pathology team of AstraZeneca, and AstraZeneca collaborated with Roche for commercialization of this technology. And Roche very recently received the FDA breakthrough device designation for this first AI-driven companion diagnostics for non-cell lung carcinoma. Next, I'll take you through what is the workflow here. So the whole system consists of a Ventana TROP2 RxDX assay. This is the catalog number EPR243. It requires an OptiView DAB detection kit, obviously the benchmark ultra auto stainer for the tissue IHC staining. Then the whole slide scanning can be done on Ventana DP200 or DP600. The algorithm is now integrated into the Navify digital pathology image, which will looked into the different aspects of QCS and then generate an automated scoring. And then looked into that, the pathologist can sign off the report. So that's the workflow in a nutshell. So at the end, what are the pros and cons? Pros, very clear, more accurate patient identification. It improves consistency and reliability, reduces the subjectivity. It's the automated process. It enables precision oncology. That's what we have seen in different trials. It may drive the adoption of digital and computational pathology because now it will be actionable. Digital and computational pathology would be actionable. What are the cons? It requires adoption of expensive digital pathology workflow solution. new workflow integration challenges, and I am sure Roche and other companies will help the pathologists for the integration process. Wider clinical validation warranted. Hopefully, as we get more clinical trial data, this can solve that. And limited application as of now for TROP2 in lung cancer. Hopefully, it will come in other cancers also. And computational pathology enables greater patient identification and more precise clinical outcome prediction. I'll stop here. If anybody has any question, we'll be happy to take it. Thank you so much.
Thank you, Dr. Shivankar. It was indeed a very informative and a new topic, and I have also learned about this little bit about computational pathology through your this thing lecture, and I'm sure all the delegates, for them also it's a very new, and they have learned about this new concept of computational pathology. And yes, of course, with the future on clinical validation and the clinically actionable part, computational pathology as in clinical actionable part. So now we move on to our last but not the least session, which is an important topic. And as a pathologist, yes, tissue, and it's very important. Tissue is an issue. Optimization of tissue for biomarker analysis. With the new multiple biomarker, on one hand, we have NGS-based testing, and on the other hand, we have IHC, immunohistochemistry-based biomarker testing. And of course, many times we have minimum tissue which is available, and we have to take success out of whatever tissue is available. So, and because this makes a very critical in decision taking decision on the treatment part. So for this, I invite Dr. Lavanya Namru. She's a senior scientific officer in Indo-American Cancer Hospital and Research Institute at Hyderabad. Over to you, Dr. Lavanya.
Thank you, Dr. Vivek, and thank you, organizers, for giving this opportunity. So, is my screen visible?
Yeah, it's visible.
Okay. Yeah. Thank you, for organizers, for giving this opportunity and giving the opportunity to speak on a tissue issue, because that is more important. And the before speakers have enlightened us about the emerging markers and their role in the TKI therapies for the patient. But what all is needed is main thing is the tissue to test all the biomarkers. So how good is the tissue to perform this biomarker testing? We'll have a journey in this. So for us, if we look into it, when the biopsy is done, mainly the biomarker testing at diagnosis and post therapy also, the biopsy will be a small biopsy most of the times, except the surgical specimen, where the tissue will be more. But when the biopsy is small and you have n number of markers to be tested and more emerging markers also to be tested, how to preserve this small biopsy for along with a diagnosis, IHC testing, and a molecular testing, we'll have a journey in this. So the main learning objectives is a tissue journey, how the tissue is handled for IHC and a biomarker and a diagnosis purpose, how the journey goes for it, right from the tissue acquisition to the reporting, and what are the different phases of a biomarker we are going to see, and what are the main highlights is, what are the critical pre-analytical steps we have to optimize it, and what will be the artifacts. If the artifacts are there, what will be the data looks like, and how to take precautions or to remove the artifacts, and root causes of the test failure we have to identify, and what are the best practices in controlling the pre-analyticals. All this will help us to maintain the integrity of the specimens for the downstream molecular and the IHCs in testing. So we see a tissue journey. Once let us have a journey. How a tissue journey starts. Once a oncologist prescribes a test, then the tissue sample collection is done by an interventional radiologist or a surgeon. Then after the collection of the sample, then it will go to the lab for initial diagnosis by the pathologist, where initial diagnosis will be done and IHC will be done to confirm the diagnosis. Along with that, pathologist will be the main person to manage the tissue for the further biomarker testing and the further IHC testing also. And after the initial diagnosis has been done, then it is going for a biomarker testing or analysis. It either goes to the IHC lab or a genomic testing. done in the IHC along with the genomic labs. Then after the biomarker testing is done, it will go, the report will be going to the oncologist. So this journey is actually starting with the oncologist, again ending with the oncologist after receiving the report. But in this process, there are four main processes or the steps that is going, and multiple team is involved for its small tissue also to give a biomarking as well as a diagnosis result. So this enlightens us that there should be a multidisciplinary team which should be coordinating well for the tissue to be preserved well for the further downstream diagnosis as well as the downstream biomarker testing. So what are the different phases of biomarker testing? We can divide the biomarker testing into three main phases. One is an pre-analytical phase, analytical phase, and the post-analytical phase. In the pre-analytical phase, you can observe there are many steps involved. One is a sample collection and stabilization, sample processing and management, how to transport that sample after it has been processed and how the sample should be stored for a future testing also. So analytical phase comes where the biomarking is testing IHC or you can say molecular testing, and post is analytical is the reporting and what will be the errors. But here the emphasis is on the pre-analytical. Just have a look that pre-analytical has made main and the many steps compared to analytical and post-analytical. So there is a higher chance that the errors will be more in pre-analytical also. So pre-analytical process, if it is stabilized properly, the accuracy of the testing and the reliability will increase a lot. Just to have a look, what will be the scope for the laboratory errors? If we divide it into the three parts, you can see that pre-analytical errors in many of the labs, there is around 60 to 75 errors are occurring in all the laboratories. It is like an hidden iceberg. Whereas the post-analytical are comparatively 30%. So what are the critical pre-analytical processes is, we again reiterate that it is sample collection, processing, transportation, and storage. This is data from our own institute. When we were performing the EGFR testing a decade ago, we have started the EGFR testing by real-time PCR. When we started in-house blocks where the pre-analyticals were in a place, we were able to perform the test in about 74% of the blocks. The failure rate was very, very less. It's around 26%. Whereas the outside blocks, that is the referral labs and other labs, where the tissue implant was prepared and sent as a block for us, the failure rate was around 73%. You can very well see that the pass rate, that means EGFR test reported was on 74% for in-house block, whereas the failure rate for outside blocks is around 73%, which is very, very high. So pre-analyticals are definitely playing a role, and how to control this, we'll have a look. Again, we'll see what are the in the pre-analytical process, what are the main steps that are we have to see. One is after the cold ischemic time, after the tissue is acquired, how far we can, how fast we should and we must stabilize the tissue, and how the volume of a specimen, the type of the fixative and the time of fixative will affect the tissue integrity, and the method of processing, like using a paraffin wax and the temperature, controlling the temperature of the paraffin. All these things, how it affect the quality of a tissue, and section cutting. After the block has been prepared, how you should preserve the tissue in the block for all the tests. That is mainly done in the section cutting also. Though the block has enough tissue and a larger tissue also, there will be always a shortage when and it is coming to a molecular or a downstream application. So section cutting also plays an important role for the preservation of a tissue. Before just I want to show our data like pre-analytical, especially the basic techniques of molecular. I'm going to show you a data, how a good data looks and how a bad data looks. So good data is this is a Sanger sequencing, we can say electrophotogram, where you can see nicely the peaks of all the 4 nucleotides. This is a good data. So what is a bad data? So when the pre-analyticals are not in process, there is an overlap of the peaks where the data we cannot read. This is called a screwed up data. In Sanger, I'm giving you an example of Sanger because it's easy to understand primarily, and it will help us to know that the pre-analytical errors when you do a molecular, this is how a data looks like, which is not interpretable and which is not reportable. So everyone will have a doubt why on FFP block the molecular data fails, because the nucleotides cannot be read as it has to be read. So overlapping of a nucleotide with a background noise, none of them can be done. Neither the mutation detection, expression or any analysis. So this is another data, though it is looking like an overlap of two sequences, but still it is not a good data for an interpretation or for a patient report. And this is how a data looks like for a Sanger sequencing results. And here I'm showing you an example of a real-time PCR. This is an example of an EGFR deletion 19 positive with a control where you can see a good amplification curves. So when it is not block is not good, how did we get a data? We got a data where all the mutations have amplified. Three mutations have amplified, the internal controls have amplified, and the four mutations other didn't show. But having three mutations, not having a good curve is an indication that the sample or the DNA extracted from the FFP block where the pre-analyticals are not good is not good because it is not able to amplify it. That is the one of the reasons. Here you can see another example where there is no amplification for anything, not even an internal control. So when you don't see an amplification, there's no result at all. So this is how the results will get skewed up when the pre-analyticals are not in place. What are the best practices to in controlling the pre-analyticals? We'll go through. First one is the sample collection and stabilization. When the sample is collected, you have to immediately stabilize it, and there is a time period recommended for it because within the best time period recommended is a 1 hour. What will happen is for a DNA and RNA, as Dr. Tripti has emphasized, for a MET exon 14 skipping, you need an RNA. You remember we have to collect the tissue for DNA and RNA together in the same tissue block. So how it is going to maintain, but the structure wise both are different. To maintain the integrity of RNA especially and the proteins, you definitely have to maintain these pre-anticles. The stabilization of a tissue at the earliest will preserve the integrity of the nucleic acids, which will help further. So to maintain the integrity of the nucleic acids especially, you have to stabilize the tissue at the earliest. So the recommended time for stabilizing a tissue is less than 1 hour. And what are the prefixation factors that can affect is there are two types of factors, constant factors and variable factors. What will affect the constant factors when the tissue is being acquired? The anesthesia, nature of anesthesia, duration of anesthesia, and injury will be constant. That they cannot change. But sometimes when the anesthetic drug is still carried on in the tissue, what will happen is the amplification or NGS and the PCR, there will be no amplification. It will not work if the anesthetic drug is there. So that is also one of the hindrances for a molecular testing we have to remember. And now what is the variable factor is the prefixation. So that varies according to the lab protocols, but the established time is less than 1 hour is recommended for a molecular testing. So methods of stabilization are the prefixators, what to be used best. So what are the factors that affect the prefixators? Is the chemistry and the mechanism of action of the fixative and the tissue penetration. How good the fixative is penetrating the tissue to stabilize the cellular compounds and the nucleic acids there. And what is the condition of fixation? What are the environmental conditions which should be kept in mind is the temperature, duration, pH, osmometric, the concentration. According to the size of the specimen, and the volume of the fixative should be fixed so that the penetration of the fixative is very well, is penetrating into the tissue and is getting stabilized very well. So the normal recommendation is the 10% buffered formalin And 70% ethanol is mainly used only for the cytological samples, not for the histological analysis. And for the bone samples, acidic decalcification should be avoided, as acidic decalcification will degenerate the RNA of the DNA. So that cannot be used for any molecular assays. Here, one thing we have to remember, the main molecular assays, either NGS or real-time PCR or anything, or a ddPCR, is based on the principle of amplification. So PCR amplification only. So the first primary basic step is a PCR amplification. It should happen for any kind of the downstream molecular high-end assays. For the amplification to have, the DNA RNA should be integrated as a strand. If it is not integrated as a single strand, the PCR will not amplify. So integrity of DNA RNA should be maintained. How it is best maintained is the fixator should be good. How good the fixator can be? According to the tissue volume, the fixator should be fixed, and the pH and the temperature should be maintained well. If the tissue volume is either less or more, your osmosis will change, the pH will change, the temperature will change, and immediate degradation of the RNA is for guarantee before the DNA. So many of the times in the block which has been sent for NGS, they will be having a mutations positive, but RNA, it is a fail. Fusions are fail. So again, the report is only half done. You will have only a mutations report. There will be no fusions report. So again, they have to approach an IHC or other approach to test for the ALK or ROS. So for at a go, if you want to conserve your tissue and preserve it for all at a time for a higher many biomarker testing, always remember that a tissue is being preserved both for RNA and DNA. And the method of processing and storage, where the paraffin and the alcohol plays a major role in dehydrating the dehydration and fixation of the tissue in the blocks, and the tissue processor should be maintained very well. Maintaining a high quality reagents is very, very important, because when the paraffin changes is not of good quality, though the block has been tissue has been fixed in the block, when it is coming for a section cutting, and so the tissue again is coming out, there will be break in the paraffin block, which might lead to a breakage of a tissue. In those conditions, the tissue degradation will be faster, as higher, and the fragmentation of the sample for a DNA and RNA will be higher. So that is again a loss of a sample. After doing all this process, when you don't take care of these minute things, but the most essential things, your sample loss will be very, very high, in spite after acquiring the tissue also. So you have to remember, though they are smaller, minor things, they are the most efficient things for the tissue to be preserved very well. And you have to always take a high quality paraffin. Example, I'll tell you. We have been participating in an EQUAS program, for an international EQUAS program, where they used to give us only one section for NGS testing of all the 14 to 17 mutations, or only one section of 10 microns, or a real time. All we have to do is, or whatever you're doing as a panel, you can do either by real time or NGS. That is not, but the time of the digestion with xylene was very, very less compared to our blocks. Then we have refined ourselves for a more good quality paraffin. That has given us higher volume, or you can say higher amount of DNA and RNA was obtained when we have refined on the quality of the paraffin and the alcohol. So this is our experience. When we have extracted more amount of the quantity and the quality of the nucleic acids increased, which has led to better preservation of the sample and the better reporting of the samples, because the fragmentation was less, the amplification efficiency was good, and the detection rate of the biomarkers was good. So that has helped us in that way. And once the nucleic acids have been extracted, you can very well preserve them in the -80 or a deep freezer for more than 10 years. So how good so this is again the quantity and the quality of the nucleic acids has been said, but you have to remember that how good you have to preserve the DNA separately and the RNA separately. they have to be preserved very, very well, because RNA immediately they have to be put into the -20 to -80, whereas DNA can stay in -20 for more than a week. But preserving the nucleic acids from FFP is different from the preserving the nucleic acids from the blood samples. Those precautions should be taken up when you're preserving your nucleic acids for a long-term storage. So how you can best conserve the tissue also. Initially, when the tissue has been received, you can separate them into two blocks, one for a regular diagnosis and IHC testing, and the other one separately with a more tumor volume as well as a tissue area for a high-end molecular testing. This will help us in preserving the tissue, conserving the tissue, as well as the advantage for a molecular testing compared to IHC will be you can use the tissue as a rolls, not as a sections. So that makes a lot of difference in preserving the tissue for molecular testing. How to conserve a tissue? As I said, like you can either divide the blocks into two blocks and use HNE and histological diagnosis one, and IHC for further testing. Also for fish, you can preserve. For molecular, where you don't need a sectioning, where it is more of a trim tissue, you can also take an advantage, like when they are trimming the tissue for IHC or an HNE, you can collect those trim tissue for a molecular testing like NGS and PCR. Or at the same time, if as a team they're coordinating and the sections are being cut for a reflex testing at a time, like these two sections are for a HNE, after HNE has been done, these sections are for further IHC markers, and these sections are for fish, and these are preserved for a further testing. When sectioning is done, it is preserved on the slide. But for molecular testing, you have to remember they are trimmed, they are rolls, not sections. So the trimming material can also be used to get more yield of your nucleic acids. That way, it will increase your yield of the nucleic acids, and the tissue which is getting wasted as a trim can also be used, the best used for a molecular testing. So pre-analytical history, what will happen is we have seen that cold ischemic time, the time of the fixator, the paraffin type, and the quality of formalin, all these things are best maintained. But when you document the things properly, documentation helps us to troubleshoot the things, and troubleshooting will always give you a better results. So always a documentation is important for us. In EQUAS programs, they emphasize on documentation because the error which is done now can be rectified for the next time. So that way the future errors will be reduced. So clinical samples are always not purely tumor samples. They can be dilution of a tumor DNA with a non-tumor DNA, that is heterogeneity, and areas of necrosis, hemorrhage, and extracellular mucin with marked fibrosis can be there. And bronchial biopsies, if though it is having a higher tumor percentage, fragments will be there. We have to remember that fragmentation is not indicated in a tumor percentage when you see on a tissue. So how you can know? First thing is you have to first understand if there is a background like necrosis or hemorrhage. Don't go for an higher end panel testing based on NGS where it requires more of a tumor tissue and a tumor volume. You can opt for a lesser methodologies like a PCR or a ddPCR, where the tissue can be best used before it is showing a failure on NGS. That is one way to do. And how good the volume of the DNA and the tumor percentage is. If the tumor percentage is less, always prefer either a real time or a fish compared to NGS. So selection of the methodologies based on the tissue integrity as well as the tumor percentage will help to save the tissue for a biomarker testing. These practices will help you for a patient report. And tumor adequacy can also be mentioned in the report so that it will indicate that this block is sufficient enough for further testing. So they can decide whether it has to be going for NGS or for a real-time PCR testing. So these are this is one of the paper published from India where they have suggested guidelines how best to take the section cutting so that it is best suitable for each methodology to be used. Here I want to emphasize that when you're taking the rolls, you don't have to stick to a 5 micron things. Even for molecular testing, you can go for a 3 microns because it is only a digestion you can do. So, but when you're taking a 3 microns or a 5 microns or 10 microns, you have to know that pre-processing with the xylene should be proper, and according to the section thickness, it has to be optimized so that you will get better yields of your molecular nucleic acids, either DNA or RNA. That is one of the key points we practice here. Just I want to give you a small intro about a European Molecular Genetics Quality Network, which is an EQUAS program where more than 25 countries are participating in that. I actually got an opportunity to be an assessor from India, only assessor for lung scheme from India. This EQUAS schemes helps us to uh, streamline the process of the molecular and genetic testing. So participating in such EQUAS programs will help us. What we have learned is to best use the sample in a best way, and how to refine the molecular processes to give a good molecular results, and how the panel should be decided according to the need of the patient. That also helps us a lot. So participating in EQUAS programs is also good. And summary, the accuracy of the molecular testing can be accomplished if the quality and the quantity of the specimen being analyzed has been impaired by inappropriate processing and handling. So we have seen that if the quality of the and the quantity of the specimen is not good, the molecular testing, how results are coming out. Maintaining the integrity is always important so that the loss is very less, and expert recommendations has to be followed to which will help us to minimize the pre-analytical errors. Thank you.
Thank you, Dr. Labanya. You have nicely elaborated that pre-analytical errors, and hopefully our pathologists and the fellow will take note and they will start practicing in their own labs so that there can be less failure rates, and when we can get more outcome and decision, it will help in decision taking for the treatment part. Now we are about to conclude this webinar, and for the vote of thanks and concluding remark, I would like to invite Dr. Sushant Vinarkar. Over to you, Dr. Sushant.
Thank you, Dr. Vivek. Thank you, Dr. Vivek, for taking up this session. And it was a very interesting session to note. I mean, emerging biomarkers in lung cancers. So, we are very well aware of the routine biomarkers tested in lung cancer. The molecular testing facilities generally look for EGFR mutations, ALK alterations, ROS alterations. However, today we had an opportunity through this webinar to learn about the emerging biomarkers. What we learned from this webinar was the key takeaways from this webinars are basically we saw MET alterations coming up, especially in the advanced lung cancers post TKIs where progression has taken place. MET alterations act as a resistance mechanism. In MET alterations, we saw overexpressions, amplifications, and gene mutations, and these are to be tested by three different modalities of testing. We also saw HER2, which is a biomarker relevant in gastric cancers and breast cancers coming up in lung cancers. Again, overexpression, amplifications, and gene mutations of HER2 are becoming important. And both MET and HER2 are going towards targeted therapy as well as are the prognostic markers in the lung cancers, especially non-small cell lung cancers. The most interesting part of the webinar, which probably I also had an opportunity for the first time to hear, was TROP2. TROP2 is a receptor against which basically newer drugs are emerging, which are in clinical trials. Dato-DXd is the drug that was mentioned. Interesting point was the testing phenomenon that we saw, the computational pathology, QCS and NMR scoring for TROP2 based on the IHC which probably would be coming up in the near future. And probably with that, AI would be entering the realm. AI has already taken the most of the part of our daily life, and now it would be surely coming up in lung cancer through TROP2, QCS, and NMR IHC. The last session was again very interesting, where we saw the journey of the tumor through the pre-analytical, analytical, and post-analytical factors. The pre-analytical factors are the most important factors which govern the tumor quality, the FFP tumor block quality for the testing, especially of molecular testing that is there. And what we learned is that the pre-analytical factors should be standardized, they should be controlled, and should be monitored also in the laboratory. Each and every part of the pre-analytical factors need to be monitored also. And expert guidelines are present, and we need to utilize them so that we have appropriate molecular testing performed, and proper results are derived for patient healthcare from these molecular testing. So at the outset, I would like to thank our speakers. The first speaker was Dr. Santosh Reddy, Dr. Trupti Pai, thereafter Dr. Subankar for introducing TROP2, and Dr. Lavanya for taking us through the journey of the tissue through molecular testing. I would also like to thank our attendees who have attended this webinar, and to MPAI and IAOI for arranging this webinar. So, since I don't see any questions coming up, I would call this session to be closed. Thank you very much.
Thank you.
Thank you, everyone. Good night.
Thank you.
Thank you.
Thank you.